Hello and welcome to today's session. Today we are looking at the human skeletal system. And the human skeletal system, we're looking at the functions of the bones and the skeletal system, looking at the structure of bones, both macroscopically and microscopically, that is histology of a bone. Number four, we'll be looking at describing the blood and nerve supply to the bones, and we'll be considering a long bone. Next, we'll be looking at explaining bone formation patterns, both intramembranous ossification and echochondrial ossification. Then we'll look at the different types of bones and their functions. And lastly, we'll be able to describe the division of the skeletal system. This includes the axoskeletal and the appendicular skeleton. So, generally, those are will be our seven objectives. So on the introduction, we are saying that a bone is composed of several different tissues working together. So a bone, or sometimes is referred to as an osseous tissue, will be or together with the cartilage, dense connective tissue, epithelium, adipose tissue, and nervous tissue, all will be consisting of this bone. So for that reason, now that the bone consists of different types of tissue, we'll be referring to each individual bone as an organ. Remember, organelles form cells, cells form tissues, tissues form organs, and this is where we are. So the entire framework of bones and their cartilages, along with ligaments and tendon, constitute what is our topic, and that is the skeletal system. Bone tissue makes up at about 18% of the weight of a human being. Okay? Let's look at the functions of bones and the skeletal system. Well, we have at least 8 functions here. Number one, we have support, and you find that the skeleton normally serves as a structural framework for the body by supporting soft tissues and providing attachment points for the tendons of most skeletal muscle. Also, on number two, protection, you find that the skeletal protects the most important vital organs from injury. For example, the cranial bones, they do protect the brain. The vertebrae, that is the back, will protect the spinal cord, and the rib cage is going to protect our one heart and our two lungs. Bones also assist in movement, in that you find that most skeletal muscles, they attach to the bones. So when they contract, they pull the bones to produce a movement. Also, bones are important in mineral homeostasis, that is, they store and release. Bone tissue stores several minerals, especially calcium and phosphorus, which normally contribute to the strength of bones. So it stores about 99% of body's calcium. On blood cell production, within the bones, we have a connective tissue called red bone marrow. And this one is found in the spongy bone section. It produces red blood cells, which are referred to as the erythrocytes, white blood cells, the leukocytes, the platelets, the thrombocytes, and this is all done through a process referred to as hematopoiesis. Lastly, we have the triglyceride storage, and here we have the yellow bone marrow, which is normally found in the medullary cavity. This one consists of mainly of adipose cells, which normally stores triglyceride. These stored glyceride are potential chemical energy reserve. Okay, so those are the different functions of the bones and the skeletal system. Looking at the structure of a bone, and we will be starting with macroscopic view. And microscopic view will be analyzed by considering the parts of a long bone. And here we will be taking the humerus, this is the arm bone, as the example. And a long bone is defined as a bone that has greater length than width. Okay? So one of the major parts of it is the diaphysis. And diaphysis, this is the bone's shaft or body. It is normally long, cylindrical, and it's the main portion of a bone. Followed by the epiphysis. The epiphysis will have both proximal and distal ends of the bone. Then the metaphysis, these are the regions between the diaphysis and epiphysis. In a growing bone, each metaphysis normally contains an epiphyseal layer of hyaline cartilage that allows the diaphysis of the bone to grow in length. So, when a bone ceases to grow at around age 18 to 21, and 18 is more common for the females compared to 21 for the males, the cartilage in the epiphyseal plate is replaced by a bone, and the resulting bone structure is known as the epiphyseal line. Guys, it's important when you look at the HIV world, we have a common drug, TDF. This is tenofovir disoproxil furoate, which is normally administered to individuals who are at least 15 years and weight of 35 kg, and in most cases we are trying to see if the growth plate has already fused, because TDF normally interferes with bone growth and bone density. So next we have the articular cartilage, and this is a thin layer of hyaline cartilage that normally covering the part of epiphysis where the bone forms an articulation or a joint. So throughout the bone we have these articulation points. The end points of a bone will be referring to it as the articular cartilage. Remember, the role of articular cartilage is to reduce friction and absorb shock at freely moving joints. We have different types of cartilage if we will try to reflect on it. So that hyaline cartilage is the most common one and is found in the ribs, nose, larynx, and trachea. It's normally the precursor of bones. Fibrocartilage is also another type of cartilage, and it's found in the intervertebral discs, joint capsule, ligaments. And lastly, we have elastic cartilage that is normally found in the external ear, epiglottis, and the larynx. So, the articular cartilage covers the end points of the bones, but the rest of the surface of the bone is covered by the periosteum. Periosteum is a tough connective tissue sheath that is normally associated with blood supply that surrounds the bone surface wherever it is not covered by the articular cartilage. It's composed of the outer fibrous layer of the dense irregular connective tissue and an inner osteogenic layer that consists of cells. Some of the cells enable the bone to grow in thickness but not in length. Remember, in length is because of the hyaline cartilage, the one that is domiciled in the metaphysis as the epiphyseal plate. So the periosteum also protects the bones. It assists in fracture repair and helps nourish bones tissue and serves as an attachment point for the ligaments and tendons. The periosteum is attached to the underlying bone by perforating fibers. We call them the shafts, and these are just thick bundles of collagen that extend from the periosteum into the bone extracellular matrix. Another part of this macroscopic structure is the medullary cavity or the marrow cavity, and this one is a hollow cylindrical space within the diaphysis that contains fatty yellow bone marrow and some numerous blood vessels in adults. So this cavity minimizes the weight of the bone by reducing the dense bone material where it is least needed. So the long bones tubular design provides maximum strength with minimum weight. So guys, you can see the rest of the body part is covered is the diaphysis. Okay, but the end points are covered by cartilage. So we call the articular cartilage. Okay. So in between we have the proximal epiphysis and the distal epiphysis, followed by the metaphysis. Okay, the metaphysis. This one is the one that this one is the region between the diaphysis and epiphysis. It contains the epiphyseal plate. This is the growth plate in bones, or the epiphyseal line in adults. It could having the epiphyseal line for adults or the epiphyseal plate, the growth plate in children. Okay, and it's responsible for longitudinal bone growth. Okay, then the rest we have the spongy bone at the proximal end. Okay, and this one will be containing the red bone marrow responsible for production of RBC, white pieces, and the thrombocytes. Okay, thank you. Histologically, we examine the structure of a bone at a microscopic level. We say that it contains abundant extracellular matrix that surrounds the widely separated cells, just like any other connective tissue. Find that extracellular matrix for the bones will be about 15% water, 30% collagen fibers, and 55% of crystallized mineral source. So the most abundant mineral source is calcium phosphate, which normally combines with other minerals and crystallizes in a process referred to as calcification. And this process is normally initiated by bone building cells known as osteoblasts. So we have different types of bone cells, and we have 4 types of cells that are present in our bone tissue, and they include osteogenic cells, osteoblasts, osteocytes, and osteoclasts. So osteogenic cells are unspecialized bone stem cells, and they are derived from the mesenchyme, the tissue from which almost all connective tissues are formed. They are the only bone cells that are able to undergo cell division, resulting into or developing into another group of cells that we refer to them as osteoblasts. So osteogenic cells are found along the inner portion of the periosteum, in the endosteum, and in the canals within the bone that contain blood vessels. So after looking at osteogenic cells, we look at the osteoblasts, and osteoblasts are bone forming cells. And the ending blast in the name of a bone cells or any other connective tissue, it means that the cell secretes extracellular matrix. So the osteoblasts will secrete and synthesize collagen fibers and other organic components needed to build the extracellular matrix of a bone, and they initiate the calcification process. So as osteoblasts surround themselves with extracellular matrix, they become trapped in their secretions and become another group of cells we refer to as the osteocytes. And the ending site in the name of a bone cell means that the cell maintains the tissue, is the mature cell. That's why we are saying that osteocytes are mature bone cells and are the main cells in the bone tissue and maintain its daily metabolism, such as exchange of nutrients and waste with the blood. So, like osteoblasts, osteocytes do not undergo cell division. Okay. Another group of cells, we have the osteoclasts, and this is the last class of the bone cells. They are huge cells derived from fusion of as many as 50 monocytes. 50 monocytes is just monocytes are just a type of white blood cells, and I'll be showing you the other different types of white blood cells in the next slides. So this one, they are concentrated in the endometrium. The ending class means the cell breaks down extracellular matrix. So guys, if you remember, we have 5 types of white blood cells. They are generally divided into granulocytes and agranulocytes. So the granulocytes are neutrophils, eosinophils, basophils, whereas the agranulocytes are lymphocytes and monocytes. Okay, so this is what forms part of the osteoclasts. Okay, correct, guys. So what are the regions of a bone? So the regions of a bone may be categorized as either compact or spongy bone. Overall, we have about 80% of the skeletal bone being compact bone and 20% being the spongy bone. So the compact bone contains a few spaces and is the strongest form of the bone tissue. It's found beneath the periosteum of all bones and makes up bulky of the diaphysis of long bones. Compact bone provides protection and support and resists the stresses produced by weight and movement. Compact bones is composed of repeating structural units, the one that we call osteons or the Hervatian systems. So each osteons consists of concentric lamellae that's normally arranged around a central canal. Okay, so resembling the growth rings of a tree, the concentric lamella are circular plates of mineralized extracellular matrix of increasing diameter, surrounding a small network of blood vessels, lymphatics, and nerves located in the central canal. The spongy bone, on the other hand, is referred to as the trabecular or the callus bone tissue. They do not contain osteons, so the spongy bone is always located in the interior of a bone. It's protected by a covering of the compact bone. Okay, so it consists of the lamellae that is arranged in an irregular pattern of thin columns known as the trabeculae. Spongy bone makes up most of the interior bone tissue of a short, flat, sesamoid, irregular shaped bones. In long bones, it forms the core of the epiphysis, okay, beneath the papaline thin like of the compact and forms a variable narrow ring bordering the medullary cavity of the diaphysis. Spongy bone is always covered by a layer of compact bone for protection. Spongy bone tissue is different from compact in two respects. First, the spongy bone tissue is light, which reduces the overall weight of a bone, and this reduction in weight allows the bone to move more steadily when pulled by a skeletal muscle. Secondly, the trabecula of a spongy bone supports and protects the red bone marrow. Spongy bone in hip bones, the ribs. We have the sternum, that is the breastbone, vertebrae or the backbone, the proximal ends of the humerus and femur are the only site where red bone marrow is stored. And thus, this is the site where hematopoiesis, that is blood cell production of white blood cells, red blood cells, and thrombocytes occur in adults. So guys, we can have some differences between compact bone and spongy bone, the cancellous bone or the trabecula. Find that compact bone is dense and solid as compared to spongy bone that is normally porous. Okay. Compact bone is organized into Hervatian system, the osteons. Trabecula is arranged in lattice-like structure. Compact bone has fewer spaces between cells. We have more spaces filled with bone marrow for the spongy bone. Compact bone is present in lacuna. Spongy bone is present in lacuna with the trabeculae. Compact bone provides strength, support, and protection, whereas the spongy bone provides shock absorption and houses red bone marrow. Compact bone contains yellow bone marrow in adults, where it stores the glycerides, whereas the spongy bone contains red bone marrow that is normally active in hematopoiesis. Compact bone forms the outer layer of bones, whereas spongy bone is found at the ends of the inside of long bones in the pelvis, vertebrae, and flat bones. Compact bone is heavier due to its dense structure. Spongy bone is light due to its porous nature. And lastly, compact bone forms the sturdy outer layer of bones. It's used for structural support and protection, whereas the spongy bone provides cushion, absorbs shock, and facilitates blood cell production. In terms of blood supply and nerve supply, saying that the bone is richly supplied with blood, just like any other organ. Okay, so blood vessels which are especially abundant in the portion of bone containing the red bone marrow pass through bone through the periosteum. We could be able to see some of the differences. Epiphysis at the growing plate, epiphyseal artery, metaphyseal artery. We have the diaphysis, we have the nutrient artery, metaphysis, periosteal arteries, anastomosis between epiphyseal arteries and arteries supplying the diaphysis. Then you have the epiphysis fused with the diaphysis. This figure is able just to show you some of the blood supply arteries in a bone. So periosteal arteries, these are small arteries accompanied by nerves that enter the diaphysis through the perforating canals. We refer to them as the Volkmann's canals and supply the periosteum and outer part of the compact bone. So near the center of the diaphysis, we have this large nutrient artery, and this large nutrient artery passes through a hole in the compact bone called the nutrient foramen. On entering the medullary cavity, the nutrient artery divides into proximal and distal branches that course towards each end of the bone. So these branches supply both the inner part of the compact bone tissue of the diaphysis and the spongy bone and red marrow as far as the epiphyseal plates or lines in adults. We also have the metaphyseal arteries. They normally enter the metaphysis of a long bone, and together with the nutrients artery, they supply red bone marrow and bone tissue of the metaphysis. We also have the epiphyseal arteries. Epiphyseal arteries enter the epiphysis of a long bone and supply the red marrow and bone tissue of the epiphysis. What about the venous drainage? Veins carry blood away from long bones and are evident at three places. We have one or two nutrient veins that normally accompany the nutrient artery and exit through the diaphysis. We also have numerous epiphyseal veins and metaphyseal veins that accompany their respective arteries and exit through the epiphysis. And lastly, we have many small periosteal veins that accompany their respective arteries and exit the periosteum. Nerves accompany the blood vessels that supply the bones. The periosteum is rich in sensory nerves, some of which carry pain sensations. These nerves are especially sensitive to tearing and tension, which explains severe pain resulting from a fracture or a bone tumor. For the same reason, for those patients who are undergoing diagnostics such as bone marrow or needle aspiration, there is normally pain that is associated to it, courtesy of the bone being richly in the sensory nerves, some of which carry pain sensations. In terms of bone growth and formation, we're saying that the process by which bone forms is referred to as ossification or sometimes referred to as osteogenesis. Bone formation occurs in four principal situations. The first situation is the initial formation of a bones in an embryo and fetus. So bone ossification or osteogenesis happens or begins at around the 6th week and 7th week of embryonic development and continues. It's important to note that the first bone to ossify in a developing embryo is the clavicle. At approximately 5 weeks of gestation, primary ossification of the clavicle proceeds by membranous ossification of two centers with no prior cartilaginous enlargement. Both will soon fuse. So the growth of bones during infancy and adolescence is the second principal time where we have bone growth. Just to facilitate the growth in infancy, childhood, and adolescence until their adult sizes are reached. We have the remodeling of the bone as another principal area, and this involves the replacement of old bone by the new bone throughout life. And most of the time, it happens every 12 years. Lastly, we have the repair of fracture and breaks in bones throughout life. So those are the four principal situations when bone growth happens. Okay, so bone growth in length because of the cartilage enlargement. Cartilage is normally replaced by bone. Cartilage grows and then cartilage is replaced finally by the bones. We have the remodeling that is normally done. So bone is reabsorbed at this point here, and the bone is added by a positional growth here. Okay. So the first pattern of growth formation, we can look at now the patterns. So initial bone formation in an embryonic fetus. The embryonic skeleton is initially composed of the mesenchyme in the general shape of bones, and is the site where cartilage formation and ossification normally occur during the 6th week of embryonic development. So bone formation normally follows any of the two patterns, and all these patterns involve replacement of pre-existing connective tissue with the bone. So they do not lead to differences in structure of the mature bones, but they simply different methods of bone formation. Intramembranous ossification, the bone forms directly within the mesenchyma, which is arranged in sheet-like layers that resemble membranes. In the second type, and echochondral ossification, bone forms within a hyaline cartilage that normally develops from the mesenchyme. Intramembranous ossification is the similar method of the two bone formation patterns. So, the flat bones of the skull, most of the facial bones, the mandible, okay, and the medial part of the clavicle is normally formed through intramembranous ossification. Also, the soft spots that normally help the skull pass through the birth canal later harden as they undergo intramembranous ossification. So, it follows this process. Number one, we normally have development of the ossification center. So, at the site where the bone will develop, specific chemical messages normally cause the mesenchymal cells to cluster together and differentiate first into osteogenic cells and then osteoblast. The site of such a cluster is normally referred to as the ossification center. So osteoblast secretes the organic extracellular matrix of a bone until they are surrounded by it. The second, now after you're done with ossification center, we go to calcification. So the secretion of extracellular matrix will stop, and the cells now called osteocytes will lie in the lacuna and extend their narrow cytoplasmic processes into canaliculi that radiate in all directions. So within a few days, calcium and other minerals are deposited and extracellular matrix hardens and calcifies. This is the process that we refer to as calcification. From calcification, we now go to the formation of the trabeculae. So as the bone's extracellular matrix forms, it develops into a trabeculae that normally fuse with another to form a spongy bone around the network of blood vessels in a tissue. So connective tissue that is associated with the blood vessels in the trabeculae differentiates into the red bone marrow. So last we have the development of the periosteum. So in conjunction with the formation of the trabeculae, the mesenchyma condenses at the periphery of the bone and develops into a periosteum. Eventually, a thin layer of compact bone replaces the surface layers of the spongy bone, but the spongy bone remains in the center. Much of the newly formed bone is remodeled, and remodeling meaning it will be destroyed and reformed as the bone is transformed in adult size and shape. So we have those four processes. Development of the ossification center, where osteoblasts secrete organic extracellular matrix. Then you go to calcification, where calcium and other mineral salts are deposited in the extracellular matrix and hardens. Then you have formation of the trabeculae. Extracellular matrix develops into a trabeculae that fuse to form a sponge bone. And then lastly, we have development of the periosteum. Mesenchyme at the periphery of the bone develops into the periosteum. So number two, we have echochondral ossification, and this is the replacement of cartilage by a bone. Although most bones of the body are formed in this process, is best observed in long bone. So using a long bone as an example, we can go through the process that are involved in echochondral ossification. Starting in the first one that involves the development of a cartilage. So at the site where the bone is going to form, specific chemical messages cause the mesenchymal cells to crowd together in the general shape of the future bone and then develop into chondroblasts. Chondroblasts are the ones that are going to secrete cartilage extracellular matrix, producing a cartilage model consisting of hyaline cartilage. So a covering called the perichondrium develops around the cartilage ring. This takes us to step 2, which is growth of the cartilage model. So once the chondroblasts become deeply buried into the cartilage extracellular matrix, they are called chondrocytes. So the cartilage model grows in length by continual cell division of the chondrocytes. Okay, and this is normally accompanied by further secretion of the cartilage extracellular matrix. This type of cartilaginous growth is called interstitial or endogenous growth from within, and normally result in increase in length. In contrast, the growth of cartilage is thickness and is due mainly to the deposition of extracellular matrix material on the cartilage surface of the model by the new chondroblasts that develop in from the perichondrium. This process is called appositional or exogenous growth, meaning growth at an outer surface. So as the model continues to grow, the chondrocytes in its mid region hypertrophy. That means they increase in size, and the surrounding cartilage extracellular matrix begins to calcify. Once the chondrocytes within the calcifying material die because nutrients can no longer diffuse quickly enough through the extracellular matrix, as these chondrocytes die, the space left behind by these dead chondrocytes merge into small cavities that we normally refer to them as lacuna. And this takes us to the third stage, which is development of the primary ossification center. So primary ossification proceeds inward from the external surface of the bone. You have a nutrient artery that will penetrate the perichondrium and the calcifying cartilage model through the nutrient foramen in the mid region of the cartilage model. This stimulates osteogenic cells in the perichondrium to differentiate into osteoblasts. So once the perichondrium starts to form a bone, it is known as the periosteum. Okay, so near the middle of the model, periosteal capillaries grow into the disintegrating calcified cartilage, inducing growth of a primary ossification center. This is a region where the bone tissue will replace most of the cartilage. So osteoblasts then begin to deposit extracellular matrix over the remnants of the calcified cartilage, forming a spongy bone trabeculae. Primary ossification spreads from this central location towards both ends of the cartilage. Lastly, we have the development of the medullary cavity. So as ossification center grows towards the end of the bone, the osteoclasts break down some of the newly formed spongy bone trabeculae. This activity leaves a cavity that we refer to as the medullary cavity in the diaphysis. Eventually, most wall of the diaphysis is replaced by the compact bone. We have the development of the secondary ossification center. So when branches of the epiphyseal artery enter the epiphysis, secondary ossification centers develop usually around the time of birth. So bone formation is similar to what occurs in the primary ossification centers. However, in the secondary ossification centers, spongy bones will remain in the interior of the epiphysis, that is, no medullary cavities are formed here. In contrast to primary ossification, secondary ossification proceeds outward from the center of the epiphysis towards the outer surface of the bone. Then you have the formation of the articular cartilage and the epiphyseal growth plate. So the hyaline cartilage covers the epiphysis and becomes the articular cartilage. Prior to adulthood, hyaline cartilage remains between the diaphysis and epiphysis as the epiphyseal growth plate, the region that is responsible for the lengthwise growth of long bones. So we have the fetal hyaline cartilage develops, cartilage calcifies, and the periosteal bone collar forms around the diaphysis. You have formation, primary ossification center forms in the diaphysis, then secondary ossification center in the epiphysis. Bone replaces the cartilage except the articular cartilage and the epiphyseal plates. Last, you have the epiphyseal plate ossify and form epiphyseal lines. So we have 6 stages as far as echochondral ossification is concerned. And these are some of the stages, and it involves in the formation of long bones, where we have replacement of the cartilage to form a bone. So we can be able to compare intramembranous ossification and echochondral ossification. So growth in length of the long bones involves the following major events. We have interstitial growth of the cartilage on the epiphyseal side of the epiphyseal plate and replacement of the cartilage on the diaphyseal side of the epiphyseal plate with the bone by the echochondral ossification. The epiphyseal growth plate is a layer of hyaline cartilage in the metaphysis of a growing bone that consists of 4 zones. And then we have the resting zone, proliferating zone. The cartilage cells undergo mitosis. Then you have the hypertrophic zone. Older cartilage cells enlarge. Then you have the calcification zone. Matrix becomes calcified. Cartilage cells die. Matrix begin deteriorating. Then lastly, we have the ossification zone. New bone formation occurring. So calcified bone cartilage as spicule, the osteoblast depositing the matrix in this case, and the osseous tissue covering the cartilage spicules. So zone of the resting cartilage, okay. So this layer is nearest to the epiphysis and consists of small scattered chondrocytes. The term resting is used because the cells do not function in bone growth. Rather, they anchor the epiphyseal plate to the epiphysis of the bone. Zone of proliferating cartilage. This one is slightly larger chondrocytes in this zone are arranged like stacks of coins. So these chondrocytes undergo interstitial growth as they divide and secrete intracellular matrix. The chondrocytes in this zone divide to replace those that die at the diaphyseal side of the epiphyseal plate. Zone of hypertrophic cartilage. This layer consists of large maturing chondrocytes arranged in columns. And last, you have the zone of calcified cartilage. This final zone of epiphyseal plate is only a few cells thick and consists mostly of chondrocytes that are dead because the extracellular matrix around them has calcified. So osteoclasts dissolve the calcified cartilage, and osteoblasts and capillaries from the diaphysis invade the air. The osteoblasts lay down bone extracellular matrix, replacing the calcified cartilage by the process of echochondral ossification. Since echochondral ossification is the replacement of cartilage with bone, the bone of calcified cartilage becomes the new diaphysis that is firmly cemented into the rest of the diaphysis of the bone. So the activity of the epiphyseal plate is the only way the diaphysis can increase in length. So as the bone grows, chondrocytes proliferate on the epiphyseal side of the plate. New chondrocytes replace older ones, which are destroyed by calcification. Thus, cartilage is replaced by bone on the diaphyseal side of the plate. In this way, the thickness of the epiphyseal plate remains relatively constant, but the bone on the diaphyseal side increases in length. When adolescence comes to an end at about age 18 for females and 21 for males, the epiphyseal plates close. That is, the epiphyseal cartilage cells stop growing and bone replaces all remaining cartilage. So the epiphyseal plates fades, leaving a bone structure called epiphyseal line. With the appearance of the epiphyseal line, bone growth in length stops completely. So the closure of the epiphyseal plate is a gradual process, and the degree to which it occurs is useful in determining bone age, predicting adult height, and establishing age at death from skeletal remains, especially in infants, children, and adolescents. What about growth in thickness? So, like cartilage, bone can grow in thickness, okay, only by appositional growth. So, at the bone surface, we have periosteal cells that differentiate into osteoblasts, which secrete the collagen fibers and other organic molecules that form bone extracellular matrix. The osteoblasts become surrounded by extracellular matrix and develop into osteocytes. The process forms bone ridges either side of the periosteal blood vessel. The ridges slowly enlarge and create a groove for the periosteal blood vessels. Eventually, the ridges fold together and fuse, and the groove becomes a tunnel that encloses the blood vessels. So the former periosteum now becomes the endosteum that lines the tunnel. Okay? So the osteoblasts in the endosteum, in the endosteum deposit bone extracellular matrix, forming new concentric lamellae. And the formation of these additional concentric lamellae proceeds inward to add the periosteal blood vessels. In this way, the tunnel fills in and new osteon is created. So as an osteon is forming, osteoblasts under the periosteum will deposit new circumferential lamellae, further increasing the thickness of the bone. Additional periosteal blood vessels become enclosed as in step 1. So the growth process continues. Recall that as a new bone tissue is being deposited on the outer surface of the bone tissue lining the medullary cavity is destroyed by osteoclasts in the endometrium. In this way, medullary cavity enlarges as the bone increases in thickness. So guys, what are the factors affecting bone growth and bone remodeling? Well, normal bone metabolism, that is the growth in young and bone remodeling in adults, depend on a number of factors. We'll be mentioning three, starting with number one, minerals. Find that large amount of minerals such as calcium and phosphorus are needed while bones are growing, as small amounts of magnesium, fluoride, and manganese. These minerals are also necessary during bone remodeling. In terms of vitamins, vitamin A stimulates the activity of the osteoblasts. Vitamin C is needed for the synthesis of collagen, which is the main bone protein. So a vitamin D helps build bone by increasing the absorption of calcium from foods in the gastrointestinal tract into the milk. Vitamin K and B12 are needed for the synthesis of bone proteins. About hormones, saying that during childhood, the hormones most important to bone growth are insulin-like growth factors, the IGFs, which are produced by the liver and bone tissue. So the IGFs, insulin growth-like factors, stimulates osteoblasts, promotes cell division at the epiphyseal plate and in the periosteum, and enhance synthesis of the proteins needed to build new bone. The IGFs are produced in response to the secretion of human growth hormone from the anterior lobe of the pituitary gland. So thyroid hormones, the T3 and T4, triiodine and thyroxine hormone from the thyroid gland also promote bone growth by stimulating osteoblasts. In addition, the hormone insulin from the pancreas promotes bone growth by increasing the synthesis of bone proteins. At puberty, the secretion of sex hormones causes a dramatic effect on bone growth. The sex hormones include estrogens and testosterone. Okay? So these hormones are responsible for increased osteoblastic activity and synthesis of bone extracellular matrix and sudden growth spurt that occurs during teenage years. Estrogens also promote changes in the skeleton that are typical of females, such as widening of the pelvis. Ultimately, sex hormones, especially estrogen in both sexes, normally shut down growth at the epiphyseal plate, causing elongation of bones to cease. Lengthwise, growth of bones typically ends earlier in females, around 18, than in males, 21, due to the higher levels of estrogens. So, during adulthood, sex hormones contribute to bone remodeling by slowing resorption of old bone and promoting deposition of new bone. One way that estrogen slows resorption is by promoting apoptosis of the osteoclasts. What are the different types of bones and their functions? Saying that the bones of the bone can be classified into 5 main types based on the shape. Number one, you have long bones. This one, they have greater length than width, and they consist of a shaft that we refer to as a diaphysis and a varied number of extremities or epiphyses, the ends, distal and proximal epiphyses, and are slightly curved for strength. So a curved bone absorbs the stress of the body's weight at several different points so that it is evenly distributed. Long bones consist of compact bone in their diaphysis but have considerable amounts of spongy bones at their epiphysis. Long bones vary tremendously in size and include those of the femur that we refer to as the tibia, as the thigh, the tibia, the shin bone, and the fibula. We also have the humerus, the ulna, the radius, and phalanges as examples of long bones. When you look at the short bones as number 2, they are somewhat cube-shaped and are nearly equal in length and width. They consist of spongy bone tissue except at the surface, which has a thin layer of compact bone. Examples of short bones are mostly the carpals, that is the wrist bones, and most tarsal bones. Flat bone is the third class, and they are generally thin and composed of two nearly parallel plates of compact bone tissue enclosing a layer of spongy bone tissue. Flat bones afford considerable protection and provide extensive areas for muscle attachment. Flat bones include cranial bones, which protects the brain, the sternum, which protects the and ribs, which protects the organs in the thorax, and the scapulae, the shoulder blades. Irregular bones is the fourth class, and this one they have complex shapes and cannot be grouped in either of the groups. They cannot be classified as long bones, short bones, or flat bones. So they vary in amount of spongy and compact bone present. Such bones include the vertebrae, the backbones, hip bones, and certain facial bones and the calcaneus. The fifth class is the sesamoid bones. They are shaped like the sesame seed and develop in certain tendons where there is considerable friction, tension, and physical stress, such as the palms, okay, and soles. So notable, we have the kneecaps, the patella, the kneecaps. Functionally, sesamoid bones protect tendons from excessive tear and wear, and they often change the direction of pull of tendon, which improves the mechanical advantage at some point. Lastly, we have suture. That's the sixth class. We have sutural bones, and these are small bones located in the sutures, and they are classified based on where they are located. Because of certain cranial bones, number varies greatly from one person to another. So we have the sutural bones. From there, guys, we can look at the division of the skeletal system. So bones of the skeletal system can be grouped into two principal divisions, the axial skeletal and the appendicular skeletal. The axial skeletal consists of the skull bones, auditory ossicles, this is the ear bones, hyoid bone, ribs, sternum, and the bones of the vertebral column. The appendicular skeleton, on the other hand, consists of bones of the upper and lower extremities. Extremities or the appendages, plus bones forming the girdles that connects these limbs to the axial skeleton. Functionally, auditory ossicles, this is the ear bones, in the middle ear are not part of either the axial or appendicular skeleton, but they are normally grouped with the axial skeleton for convenience. The exoskeletal is the first one, and these are we look at the bones of the skull. So the skull is a bone framework of the head. It contains 22 bones, not counting the bones of the middle ear, and the rest, and normally rests in the superior end of the vertebral column or the backbone. The bones of the skull are grouped into two categories. We have the cranial bones and the facial bone. So the cranial bones form the cranial cavity, which encloses and protects the brain. Whereas so we have the 8 cranial bones. So we have the frontal bone, the 2 parietal bones, the 2 temporal bones, occiput, the sphenoid bone, and the ethmoid bone. Okay, as you can see, the parietal bones, these are pair, temporal bone is a pair also. You have 1 occiput, you have 1 ethmoid bone, you have 1 sphenoid bone, and you have 1 frontal bone. A total of 8 cranial bones. Okay, so we have the 14 facial bones. They form the face, and the mnemonic is by mouth, palate, never linked, zucchine, and vinegar. Okay, so my mouth. So we have mandible, maxilla, palatine, nasal, lacrimal, zygomatic, inferior nasal concha, and the vomer. Okay, so there are how many? There are 14. 1, mandible, axilla, vomer, inferior concha, nasal bones, the zygomatic bones, the lacrimal bones. Okay, then you can see the inside side of showing the vomer, the palatine bones, the posterior palate, and the maxilla. So there are 2 nasal bones plus 2 maxillas plus 2 zygomatic bones, 1 mandible, 2 lacrimal bones, 2 palatine bones, 2 inferior nasal concha, and the vomer, making a total of 14 facial bones. The skull has also unique features, and the skull exhibits several unique features not seen in other bones. They include the skull has sutures, the skull has paranasal sinuses, and the skull has fontanelles. So the paranasal sinuses, okay, we normally abbreviate them as the MEFs, maxillary, ethmoid, frontal, and sphenoid. In terms of the sutures and the fontanelles, we have the anterior fontanelle and the posterior fontanelle, plus the others, but these 2 are the most common one. Then we have now the sutures, the sagittal suture, the coronal suture, then you have the metopic suture, lambdoidal suture. Yeah, great. So in terms of sutures, we're saying that a suture is an immovable joint in most cases in adult skull that holds most skull bones together. Sutures in the skulls of infants and children, however, often are movable and function as important growth centers in developing skull. The names of many sutures reflect the bonds they unite. For example, if you talk of the frontal zygomatic suture, it's between the frontal bone and the zygomatic bone. Similarly, the sphenoparietal suture is between the sphenoid bone and the parietal bone. In other cases, however, the names of the sutures are not so obvious. Of the many sutures found in the skull, we will only identify 4 prominent four prominent ones. We have the coronal suture relating to the frontal or the coronal plane. It unites the frontal bones and the both parietal bones. Okay, coronal suture. We have the sagittal suture. This one unites the two parietal bones on the superior midline of the body. Okay, the sagittal suture. The sagittal suture is so named because the infant, before the bones of the skull are firmly united, the suture and the fontanelle are associated with it will resemble an arrow. So that's why it's called the sagittal suture. All right. The lambdoidal suture unites the two parietal bones to the occiput. Lambdoidal suture. Okay. This suture is named so because of its resemblance to the capital Greek letter lambda. Remember, sagittal bones may occur within the sagittal and lambdoidal suture. The two squamous suture, these are flat overlapping scales of a snake. They unite the parietal and the temporal bones on the lateral aspect of the skull. From there, we look at the paranasal sinuses, and paranasal sinuses are cavities within certain cranial and facial bones near the nasal cavity. They are most evident in the sagittal section of the skull. The paranasal sinuses are lined with mucous membrane that are continuous with the lining of the nasal cavity. So secretions produced by the mucous membranes of the paranasal sinuses drain into the lateral wall of the nasal cavity. Paranasal sinuses are quite small or absent at birth, but they normally increase in size during two periods of facial enlargement, during the eruption of the teeth, and also at the onset of puberty. They arise as outgrowths of the nasal mucosa that project into the surrounding bones. So skull bones containing paranasal sinuses are abbreviated as MEFS. We have the maxillary, we have the ethmoid, we have the frontal, and we have the sphenoid. So the paranasal sinuses allow the skull to increase in size without change in the mass, that is the weight of the bone. Okay, paranasal sinuses increase the surface area of the nasal mucosa, thus increasing production of mucus to help moisten and cleanse inhaled air. In addition, paranasal sinuses serve as resonating chambers within the skull. They intensify and prolong sounds, thereby enhancing the quality of the voice. The influence of paranasal sinuses on your voice becomes obvious when you have a cold. Okay, the passageways through which sound traverse into and out of the paranasal sinus becomes blocked by excessive mucus production, so changing the quality of your voice. Fontanelles. Fontanelles, I find that the skull of a developing embryo consists of the cartilage and the mesenchyme arranged in thin plates around the developing brain. Gradually, ossification occurs and bone slowly replaces most of the cartilage and the mesenchyme. At birth, bone ossification is incomplete. The mesenchyme filled spaces become dense connective tissue regions between incompletely developed cranial bones called fontanelles. These are little fountains, commonly called spots. Fontanelles are areas where an ossified mesenchyme develops into the dense connective tissue of the skull. As bone formation continues after birth, the fontanelles are eventually replaced with bone by intramembranous ossification. And the thin collagenous connective tissue junctions that remain between neighboring cells, the bones become sutures. Functionally, the fontanelles serve as spaces for growth of neighboring skull bones and provide some flexibility to the fetal skull, allowing the skull to change shape as it passes through the birth canal and later permitting rapid growth of the brain during infancy. Although an infant may have many fontanelles at birth, the form and location of 6 are fairly constant. Number one, we have the unpaired anterior fontanelle, and this is the largest fontanelle and is located at the midline among the two parietal and the frontal, and it's roughly diamond shaped. Okay, it's referred to as the pregma and usually closes around 18 to 24 months after birth. Number two, we have the unpaired posterior fontanelle. It's located at the midline among the two parietal and the occiput. Because it's much smaller than the anterior fontanelle, it generally closes about 6 weeks to 2 months after birth, okay? It's triangular shaped, okay? And these two fontanelles are very significant during labor and delivery because when you're doing vaginal examination, you need to locate the occiput, you need to locate the presenting part, and you need to say whether it is diamond shaped, okay, or triangular shaped. So if it is triangular shaped, you know you're working with the occiput. Okay, guys. Next we have the paired now anterolateral fontanelles. So that makes it to number 4. 1, 2, then this is paired 3, 4. It's located laterally among the frontal, parietal, temporal, and sphenoid bones and are small and irregular in shape. Normally they close at about three months after birth. We have the paired posterolateral fontanelles located laterally among the parietal, occiput, and temporal bones and are irregular shaped. They begin to close 1 to 2 months after birth, but closure is generally not complete until a year. The next component of the axial skeletal, okay, is the hyoid bone. And it is single U-shaped, is a unique component of the exoskeleton because it does not articulate with any other bone. Rather, it's suspended from the styloid process of the temporal bones by the ligaments and muscles. It's located in the anterior neck between the mandible and the larynx. The hyoid bone supports the tongue and provides attachment site for some tongue muscles and for some muscles of the neck and pharynx. The hyoid bone and the cartilage of the larynx and the trachea are often fractured during strangulation. So the primary function of the hyoid bone is to serve as an attachment structure for the tongue and for the muscles of the floor of the oral cavity. So how do you test the hyoid bone? If a hyoid bone fracture is clinically strongly suspected in a patient with a neck injury, diagnosis is normally made through radiographs, computed tomography, laryngoscopy, and surgical inspection. So can you live without your hyoid bone? Yes, you can live without your hyoid bone. The hyoid bone is a U-shaped bone located in the neck between the chin and the thyroid cartilage. It's unique because it's the only bone in the human body that is not directly connected to another bone, but instead suspended by muscles and ligaments. The hyoid bone plays a role in supporting the tongue and the muscles of the throat, and it also helps in swallowing and speech. While the hyoid bone serves important functions of the body, it's not vital for survival. If the hyoid bone is damaged or removed due to surgery or injury, a person can still live a relatively normal life. However, the absence of the hyoid bone might affect certain functions such as swallowing and speech, and it could lead to changes in the voice or difficulty in swallowing in some cases. Another component of the exoskeletal is the vertebral column. The vertebral column is also referred to as the spine, the backbone, or the spinal column, and makes up about 2/5 of your height. 2/5 of your total height. And is composed of series of bones called vertebrae. So the vertebral column, the sternum, the ribs form the skeleton of the trunk of the body. The vertebral column consists of bones and connective tissue. The spinal cord that it surrounds and protects consists of the nervous and connective tissue. at about 71 centimeters in an average adult male and about 61 in an average adult female. The vertebral column functions as a strong, flexible rod that with elements that can move forward, backward, sideways, and rotate. In addition to enclosing and protecting the spinal cord, it supports the head and serves a point of attachment for the ribs, pelvic girdle, and muscle of the back and the upper limbs. The total number of vertebrae during early development is usually 33. As the child grows, several vertebrae in the sacral and the coccygeal regions they fuse. So as a result, the adult vertebrae column typically consists of 26 vertebrae. So we have the cervical having 7 found in the neck, abbreviated from C1 to C7. We have the thoracic having 12 vertebrae within the chest, abbreviated from T1 to T12. Then you have the lumbar region between five or 6 found at the lower back and abbreviated as L1 to L5. We have the sacral. We have 5 fused vertebrae found the pelvis, abbreviated from S1 to S5. Then you have the coccyx, have the 3 and found the tailbone. There's none of abbreviation. So if you get that one, you get to 26 in number. So we have the cervical region, we have the thoracic region, we have the lumbar region, we have the sacrum, and then we have the coccyx. Sorry. So normal curves of the vertebral column when viewed from the anterior or posterior, okay, the front or back, a normal adult vertebral column will appear as if it is straight. But when viewed from the side, it shows 4 slight bends called normal curves. Relative to the front of the body, the cervical and the lumbar curves are convex, they bulge out, while the thoracic and the sacral are concave, they curve in, okay, they curve in. So the curves of the vertebral column increase in strength, helping to maintain the balance in an upright position. It absorbs shock during walking and helps protect the vertebrae from the fracture. So the fetus has a single anterior concave curve throughout the length of the entire vertebral column. At about 3rd month after birth, when an infant begins to hold its baby erect, the anterior convex cervical curve develops. Later, when the child sits up or stands and walks, the anteriorly convex lumbar curve also develops. Okay. So the thoracic and the sacral are called primary curves. Okay. And this is because they retain the original curvature of the embryonic vertebral column. Whereas the cervix and the lumbar are known as secondary curves because they begin to form later, several months after birth. It's good to know that by age 9, all the curves are fully developed. However, secondary curves may progressively be lost in old age. So various conditions may exaggerate the normal curves of the vertebral column, or the column may acquire lateral bend, resulting in abnormal curves of the vertebral column. We have 3 abnormal curves. We have the kyphosis, have the lordosis, and the scoliosis. Lordosis, kyphosis, and scoliosis are curves seen. Okay, so we can appreciate the normal one having the cervical curvature, then the thoracic, then the lumbar, then the sacral, then the coccyx. Okay, so scoliosis forming an S. Kyphosis, the exaggeration of the thoracic curvature, whereas the The lordosis will be the exaggeration of the lumbar curvature. Okay, so lordosis is normal for neck and lower back. Okay, lordosis. Kyphosis, on the other hand, is only normal for the thoracic, but exaggeration will result in that. So you could have double or single S-shaped scoliosis, the spine bends and twists simultaneously. Okay. So we have parts of our vertebrae. Vertebrae in different regions of the spinal cord vary in size, shape, and detail, but they are similar enough, and therefore we can be able to look at a typical one. Okay, so vertebrae typically consist of vertebral column, vertebral arc, and several processes. So you can be able to appreciate the spinal cord, the vertebral foramen, then we have the spinous process, the transverse process, okay, we have the lamina, we have the pedicle, then we have the body. Okay, this is this is the anterior, this is the posterior side. Okay, then you have the facet for the head of the rib to attach. Okay, so we have the bones of the thorax. Still on the axial skeleton. So there's a lot of relationship between the chest and the vertebral column. The term thorax refers to the entire chest region. And the skeletal part of the thorax, that is the thoracic cage, is a bony enclosure formed by the sternum, the ribs, and the costal cartilages, and the bodies of the thoracic vertebrae. So the costal cartilages attach the ribs to the sternum. The thoracic cage is narrower at its superior end and broader at the inferior ends and is flattened from front to back. It encloses and protects the organs in the thoracic and superior abdominal cavities and provides support for the bones in the superior in the upper limbs and plays a role in breathing. The bones of the thorax are in the thoracic vertebrae, the 12 pairs of ribs and the sternum. Connecting the upper 10 ribs of the sternum are the costal ridges. So we have the boundaries of the thorax, of the sternum, manubrium, sternal angle, the body, okay, manubrium, the sternal angle, okay, the xiphoid process, yeah. Then you have the 12 ribs, so 6 or 7 pairs of the true ribs. You have the 3 or 4 pairs of false ribs, the 2 pairs of floating ribs, okay. So we have the 2, okay. Then you have the thoracic inlet, thoracic outlets, and thoracic vertebrae. Okay, fine. Let's now look at the appendicular skeleton. The appendicular skeleton includes bones that make up the upper and lower limbs, as well as the bones of the two girdles that attach limbs to the axial skeleton. The bones of the appendicular skeleton are connected with another and with the skeletal muscles, permitting you to do things such as writing, walking, use of a computer, dancing, swimming, and playing musical instruments. So what are some of the bones of the shoulder girdle and what are some of their functions? We have the clavicle, and this is also referred to as the collarbone. It provides support and maintains alignment between the arm and the body, and also protects the nerves and the blood vessels. We have the scapula with the glenoid cavity. This is a shallow socket. This one allows a wide range of motion in the shoulder joint. We have the acromion process. This is the point of the shoulder. This one provides attachment for muscles and ligaments, aids in overhead arm movements. We have the coracoid process, attachment point for the tendons. This one provides anchorage for the shoulder muscles. Then you have the spine, divides into the supraspinous and infraspinatus fossa and provides support and anchorage for the muscles. We also have another bone, the humerus, which has the head that fits into the glenoid cavity, forming the ball and socket joint with the scapula, allowing various arm movements. Then you have the greater and lesser tubercles, provides muscle attachment points, allows attachment for muscles and ligaments, providing movement and stability. Lastly, you have the anatomical and surgical neck. This is a specific region. The surgical neck is the most common. Surgical neck is a common site for the fractures. Anatomical features provide structural support. So the neck is the most affected in that case. Looking at the pectoral, the shoulder girdle, the human body has two pectoral or shoulder girdles that attach the bones of the upper limbs to the exoskeleton. So each of these two pectoral girdles consist of the clavicle and the scapula. The clavicle is anterior bone and articulates with the manubrium of the sternum at the sternoclavicle joint, whereas the scapula articulates with the clavicle, the scapula at the acromoclavicular joints, and with the humerus at the glenohumeral joint, and this is normally referred as the shoulder joint. So the pectoral girdle do not articulate with the vertebral column and are held in position and stabilized by a group of large muscles that extend from the vertebral column and ribs to the scapula. The upper limb bones. So we have each upper limb or upper extremities as 30 bones in 3 locations. We have the humerus, and then followed by the ulna and radius in the forearm. Then the rest will be found in the hand, where we have the 8 carpals in the wrist, 5 metacarpals in the metacarpus, the palm, and the 14 phalanges, bones of the digits in the hand. Okay, so we have the arm, then we have the forearm, then you go to the wrist, then you go to the palm, then you go to the phalanges. What about the pelvic hip girdle? It consists of two hip bones, also called the coxal or the pelvic bones. The hip bones unite anteriorly to form the pubis symphysis and posteriorly to form the sacroiliac joints. The complete ring is composed of the hip bones, that is the pubic symphysis, and the sacrum forms a deep basin-like structure that we normally call as the bony pelvis, the basin. Plural of the pelvises or pelvises. Functionally, the bone pelvis provides a strong stable support for the vertebral column and pelvic and lower abdominal organs. The pelvic girdle of the bony pelvis also connects the bones of the lower limbs to the axial skeleton. Each of the 2 hip bones of the newborn consists of the 3 bones separated by a cartilage. We have the superior ilium, inferior and anterior pubis, and then we have the inferior and posterior ischium. Remember, by age 23, the 3 separate bones normally fuse together. Okay, so in summary, guys, the human skeleton has 206 bones, 80 in the exoskeleton and 126 in the appendicular skeleton. So the appendicular skeleton has the bones in the head and trunk, where the skull has 22 bones, of which 8 are cranial, 14 are facial. We also have the middle ear ossicles for convenience purposes. They are here, and there are 6 in number, 3 in each ear. Then we have the hyoid bone in the neck, which does not articulate with any other bone. We have the vertebral column, Initially, we have 33 vertebrae, but with time they fuse to form 26 vertebrae. Then we have the sternum, the chest bone, we have one, and then we have the ribs, which are 24, 12 pairs. This makes a total of 80 axial skeletal bones. On the other hand, we have the appendicular skeleton that consists of 126 bones. So the pectoral girdles, we have four bones. We have the arm with 6 bones. Then you have both hands with 54 bones. The pelvic girdle, the hip, with 2 bones. Then you have the legs with 6 bones. And the kneecap, the patella, which are 2. And with the feet with 52, giving us a total of 126 bones. So those are the 206 bones. 80 plus 126, giving us the 206 bones in an adult human skeleton. So guys, you should be able to state 5 functions of the bones. You should be able to draw and label a diagram to illustrate the long bone. Okay, you should be able to state 4 types of bone cells. You should be able to explain factors that are affecting the bone and growth. Yeah, including the vitamins, the minerals, the hormones. You should also be able to state 6 bones of the head. You can be able to classify them into the cranial bones, okay, and the facial bones in both cases. So that is the human skeleton, consisting of the 200 and 206 bones. Thank you so much.